Olá, meu nome é Sidney Klajner, eu sou cirurgião do aparelho digestivo, presidente do Einstein e membro do Board de Diretores do Institute for Healthcare Improvement, o nosso IHI. O Einstein sediou, nesses dias, em parceria com o IHI, a 9ª edição do Fórum Latino-Americano de Qualidade e Segurança na Saúde, o maior evento para debater o tema aqui na região. Nesse ano, o tema que norteou as discussões foi Tecnologia para a Equidade. O debate é extremamente relevante, especialmente no nosso país e em toda a América Latina, onde as desigualdades econômicas e sociais impõem enormes desafios também no acesso à saúde. Usar avanços tecnológicos para superar as barreiras e oferecer atendimento de qualidade onde quer que o paciente esteja está no centro das ações do Einstein para transformar a saúde do Brasil. E aqui, durante o fórum, discutimos com parceiros de diversos países como podemos fazer mais pela equidade em saúde no mundo. Aqui, eu tenho o prazer de receber aqui Kedar Mate, presidente do Institute for Healthcare Improvement, o IHI, para conversar um pouco sobre qual a importância de promover esse debate na América Latina e no mundo. Bem-vindo, Kedar. Welcome, Kedar.
Thank you. Thank you
It's
so
a pleasure
much.
to have you here again in our event.
Molto obrigado. Thank you.
Kedar, the 5 aims set by the Institute for Healthcare Improvement for healthcare system improvements are followed by healthcare organizations around the world. In 2022, the IHI placed, rightly so, the search for equity in health as the 5th aim. To make it clear to who's and those that watching us, what's the importance of setting and following this aim around the world?
Yes. Well, Sidney, first of all, thank you for the opportunity to be here and for our long partnership with Einstein. It's really a pleasure and honor. It's amazing to see the incredible developments that have happened here at Einstein over the last several years, but especially over the last week. It's been just wonderful to see. Many years ago, now 2007 is a long time ago, actually, almost 20 years ago, IHI noticed that there had been a discussion in the world about access and quality and cost. And the idea that at that time was that these three ideas were in conflict with each other. That if you gave people more access, it was going to cost more. If you spent less money, more money, you might compromise access or quality. So these things were seen as in tension, in conflict with each other. And so Don Berwick, one of the founders of the founder of IHI, and two other partners wrote something that was called the triple aim, the 3-part aim. And the idea behind the 3-part aim was that you could pursue improving the health of a whole community, a whole population, improving the experience of care of the whole population, and lowering the cost all at the same time. So this idea was very much in direct conflict with this sense that these things were fighting each other. Instead, we said, actually, the only way to achieve those goals for a health system was to do them all together, all at the same time. But very quickly, we learned that we could not do that without the workforce. You can't improve the health of a population. You can't improve the care experience of our patients. You cannot reduce costs without making sure that the workforce is attended to as well. So we added a 4th goal of improving the conditions of the workforce. And then we realized that all of that was in support of something else. All of it was in support of improving outcomes in an equitable manner across the system. Because if we don't pursue equity and we don't build it into the system from the beginning, we have the risk of making the inequities worse. So we made equity into the 5th aim. And having done so, now we think we have the full recipe for what it takes to actually drive a system to a new level of performance. There's no quality in a system. You cannot achieve high performance in a system if it isn't distributed in an equitable manner across a system, across a community, across a whole country.
Agree at all. And Einstein adopted the triple aim in 2013.
Yes.
And then the 4th and the 5th aim.
I know.
As well. And it's a way that some organizations, I wish more and more organizations pursue this quintuple aim in a way to fight against inequalities.
Just one comment on this. There's a lot of thinking in the world that's what we call either or thinking. It's this or it's that. And we think that that's probably not an adequate solution to today's problems. Today's problems need what we call both and thinking.
Yes.
It's not either access or cost. It's not either experience or quality. It's not either equity or outcomes. It's both. And if you don't pursue both, then you're missing some part of the story.
So, Kedar, I will ask another question. Like in Brazil, is an extremely unequal country, including in health. So the Southeast region, for example, where 42% of Brazilians live, concentrate 52% of the doctors, while in the North and Northeast regions, which respectively have 8.7% and 27% of the population, there are only 4.6% of the doctors. Some important projects that we run at Einstein, you know them very much, use technology in attempt to overcome this obstacle to access in that regions, like Teleames, a program in partnership with the Ministry of Health that use telemedicine to connect specialists in São Paulo with general practitioners and their patients in remote regions of North and Midwest in the country. Currently, we have a lot of points of that, more than 350 service points, and it's a low-cost and high social impact program that has been operating for more than 3 years. In which other ways you think that technology can offer a more robust contribution to improvements in access to quality healthcare? And we have just half an hour to talk.
We could be here for a long time on this one.
Yes, I know.
Look, maybe I'll describe a principle, a key principle that is a way of solving this challenge, or at least starting to solve this challenge. At IHI, we talk about this concept of moving knowledge, not people. It's very expensive to move people from one place to the next, move resources like infrastructure to build it one place to the next. In remote and very hard to reach places, it's very difficult to get roads and buildings and clinics and all of the infrastructure that you need to provide the kind of care that you want. So we have to move the knowledge. Knowledge is far easier to move. It's cheaper to move than it is to move people. So the whole concept is moving knowledge, not people. And I think that's what telemedicine programs are about. They're moving knowledge from centralized resources in the South. What you're saying is in the South, where there's a concentration of expertise, doctors, specialists, care providers, and individuals with lived experience. You have this incredible source of knowledge here. And through telemedicine and linkages like that, you're creating capacity in remote and hard to reach places. And technologies enable all of that. How do we communicate? We need technology to do that. Increasingly, we need technologies to bring material and support systems to people in these hard to reach environments and places. So the concept, I think, that underpins a lot of this is this idea of moving knowledge, which is cheaper and easier than moving the people themselves and asking them to come here. But it also makes it much easier for the people, because the people don't have to leave their homes. They don't have to leave their families. They don't have to make this long trip down to the South to actually get the care that they want and need. And so that concept of moving knowledge, not people, I think is part of the answer here. And technologies that we have available to us today really enable that in a way that we've never been able to do in the past. And
the better technology is, the better way to move knowledge to that population.
That's right. The faster, the more effective, and the closer to the person. So, now in our pockets we carry computing power that we used to have in a building like we're sitting in today. And, Google search can bring knowledge directly to wherever you are. And now with ChatGPT and AI technologies, you can talk to a bot that's able to answer your questions as if you're speaking to your doctor.
Yes.
I mean, it's amazing what is possible now.
We learned these days about it in your speech, about using mobile and how you can get access to the information.
Yeah,
and this is wonderful.
It's amazing.
Kedar, when we talk a lot about growth of telemedicine, as you said right now, we are also talking about the use of increasingly sophisticated gadgets, devices, and make remote testing, treatment, and follow-up more accurate. but this also comes at a cost. How can you think about evolving, bringing cutting-edge technology to facilitate access to health while also making it available and accessible to the greatest number of people?
Well, I think that the cost associated right now, we don't actually account for the cost of inaction. So today, we are losing people's lives. We're causing more morbidity. There's more waste in the system. We're losing people in productive years of life because we're not accounting for that cost. So yes, it's costly to use the devices, to have new technologies approach people, but we're not factoring in today the cost of not doing that. And today there's an enormous cost, I think, to excess morbidity, excess mortality in some cases, just suffering, frankly, that is unnecessary, completely unnecessary. And if you look at that on one side, and then you look at the costs associated with delivering some of these technologies, which are in some cases not very expensive. I think we think of the big expensive things, the robots that you do surgery with, Sidney, that are very expensive, right? But some of the technologies we're talking about are cell phones. I saw in India, I visited Aravind Eye Care, which is a specialty eye care institution, and they were doing diabetic retinopathy scans with an iPhone, transmitting that data to their central diabetic retinography readers, and within seconds providing an answer about a diagnosis. And then in the same moment, the person who was taking the picture had the eye drops to give to the person in their pocket if they had confirmed diagnosis. So, this is not expensive. And the relief of blindness and suffering as a result of that is enormous. Those people can stay in their jobs. They can continue their productive work. So we're not accounting for the cost of inaction, which is quite significant when we think about the relatively inexpensive costs associated with some of these technical solutions.
And these people, if they are sick, they consume another one to take care of them.
That's a good point, which is that there's more to this story. Not only are we losing those individuals from whatever job they might be doing, their families, if their families are dependent on them, they might be losing a breadwinner, so that the family falls into poverty, and there's other people that have to take care of them. So if a person goes blind from diabetic retinopathy, somebody has to spend their time taking care of that person. So we're really not accounting for all of the costs in the system when we think about these.
And this we must learn with them.
Yeah, absolutely.
The same way as the production of cheap lens to cataract. So we are talking about technology, about what it's cost-effective technology, and now we reach the conversation about AI, for example.
Yes.
Somebody are scared about AI, of losing jobs, for example.
Yes.
But this can also open doors to a path of more equity and health also. Because, as I learned today, it moves knowledge as well.
That's right.
Here in Einstein, for example, we are working 2 projects that address health conditions that are very critical in the Amazon region, of mortality rates, in maternal mortality rates. In the case of tropical disease, we have a tool that identifies, based on the photo of a skin lesion and through access to a vast image bank, the probability to be a leishmaniasis lesion or not. The second case, the tool we are developing, use generative AI to listen to the consultations and suggest even the what to do, the prescription, and also questions to the primary care physicians. All of this helps bring specialized access to remote regions of Brazil. How do you see the possibility of making use of data and artificial intelligence to promote more equity? And what do you think could be the challenges of implementing them elsewhere?
Yeah. Well, first of all, it's very exciting to hear the stories of so many things that Einstein is working on. This tool to diagnose skin conditions of leishmaniasis is amazing. I remember my early career was in global public health, and tuberculosis is very difficult to diagnose on a chest X-ray, and there's a lot of misinterpretations of the images. And I remember an early generative AI technology that I was watching was based on learning about radiographs and comparing TB images. And very quickly, it made the accuracy of TB chest X-ray reads, over 95%. And, we have to take advantage of those kinds of technologies because they allow us to do things that we were not able to do before. And honestly, they allow a level of quality of care for conditions like leishmania, like tuberculosis. These are conditions that affect generally increasingly poorer and more rural, more under-resourced settings. And so if we design our technologies to emphasize the conditions and issues of people living in harder to reach, remote, under-resourced, and underserved communities, then we have the chance of actually having the technology increase equity. But there's another possibility, right, which is that we focus the technologies on the conditions of the affluent and the urban and the people that are easy to reach, and then we widen the gap between those that have and those that don't have. And so my thought here is that there is an opportunity for us to reduce the gap, but we have to be intentional about our choices. And they are choices. The technology won't make the choice for us yet. But so we, the people in the system, still make the decisions about what the AI tools that we're building today are going to focus their energy on, focus the attention on. And so long as I think we continue to emphasize equity as a principle underpinning what we grow and develop and invest in, then I think we have a chance of reducing the gap in care that we see. Maybe one last thing to say is that these technologies, people are very worried about losing their jobs. AI is coming, you see it in the headlines, in the newspapers. People are very worried about this. But we also hear at the same time that we don't have enough staff, that there aren't enough physicians, there aren't enough geriatricians, there aren't enough psychiatrists, there aren't enough pediatricians, there aren't enough fill in the blanks, there aren't enough nurses. In my country, in the United States, we have an absolute nursing shortage at the moment. We don't have enough extended caregivers like pharmacists and physical therapists and occupational therapists. So we have to find a way. These two things are happening simultaneously. People are worried about AI coming for their jobs, and yet we don't have enough people to do the jobs.
It's a paradox.
And so in a way, perhaps AI solutions can free some capacity so that we can actually provide the necessary care finally for everyone that needs and deserves it. So that's my hope. But again, that won't happen unless we are intentional about how we design our systems to actually achieve that goal of creating a workforce that's AI enabled that can reach everyone that needs care.
Great point. There is a shortage and a fear of losing jobs.
Yeah, and these
incredible.
These two things are they sit together right now, but they actually are solutions for each other.
Yes.
Right?
Yeah. So I think this is my last question. Technology is an ally when you talk about quality and safety in health, and it contributes to the monitoring of patients and the accuracy of tests and procedures. So, in your opinion, where have we evolved the most in the last decade? And where do you have room to advance when you talk about technology use and the pursuit of quality and safety in health?
I think there's a lot. The first and probably most important thing I'll say about this is that we have a lot of room to grow. There's a lot more that we need to do. We have invested a lot in technologies for the back office, for revenue cycle and working on all of the operational aspects of healthcare. There are some growing and developing digital technologies and information technologies for clinical service and use. But the area of quality and safety in particular, I think, is still relatively underinvested from a technology perspective. I still find when I travel, people using Excel spreadsheets and ways of computing quality measurement and scores, not really engaging patients except for annual samples or sometimes a periodic question that people are getting asked. It's still fairly rudimentary in terms of our investment and our understanding of quality and safety today. So there's a lot more that I think we need to be doing to both diagnose quality risks and challenges and then engineer them out of our system. Because now we work as clinicians, you and I, we work in a system that is wholly dependent on technologies. I can't go to my clinical environment and do my job as a doctor without the technologies in the system to do that. I don't know if you can, but I doubt it. So it's very difficult.
Cannot.
It's a fully technology-enabled system, and yet most of those technologies are not designed fully to help engineer out of the system errors or defects or problems that we might see or find in our system. So we have a long way to go and a real opportunity, I think, especially with AI, large language models, to start understanding the experience of care more effectively, start to understand it in a more holistic way. We no longer need to do sampling strategies. We can actually understand the entire corpus, the entire body of care experience, the entire experience of our patients that come through our systems, and use that data to now drive decision-making and engineer better choices into our system. So a long way to go, I think, still on quality and safety technology.
And sensibilize health professionals who are more skeptical because of technology, but the acceptance to, for example, decision support. I think the most difficult to convince is the health professionals, because I think the traditional way of capabilities, I don't know how, but we are very slowly engaging physicians and
but
more
that was the mistake of a lot of decision support tools. We engaged the clinicians after we developed the technology. And I think it has to be done differently. We have to bring the clinicians into the development process so that they are part of the experience of using the technology. The technology can be adjusted. It's not a fixed thing. It can be adjusted and changed, and then it will increase the adoption by clinicians. But we are fully dependent on technologies to do our jobs. And the question is, how do we make sure that we can speed the adoption by bringing the stakeholders, the clinicians and patients and family members into the design of the technologies to begin with.
So, Kedar, I want to thank you very much to be with us in this fast conversation. Kedar is an inspiration for a lot of organizations. As the head of IHI, for me, it's a pleasure to work with you in some fronts.
It's my honor.
To have you in this week in our forum and in this conversation with us. Agradeço ao Kedar por essa discussão importante e toda a parceria na construção desse fórum junto com o IHI. E eu agradeço também a você que nos acompanhou até aqui e convido a você assistir às demais conversas que nós gravamos durante a 9ª edição do Fórum Latino-Americano de Qualidade e Segurança na Saúde, na playlist dedicada ao tema aqui no canal do Einstein no YouTube. Um abraço a cada um de vocês.